I'm Jeff Mulgan from Nesta. Really want just to say welcome to all of you. Welcome to probably the best place in London this evening to have a medical emergency, though we hope none of you do. And really to say it's a real pleasure to be able to host this event and share a bit more light on GoodSAM, which we think is an absolutely fantastic initiative. Many of you already know about it, but we think it's one which has all sorts of implications for a good future of healthcare and indeed public services more generally. One of the reasons I'm interested in it is that I have a background in telecommunications. My PhD is in telecoms. I worked a lot on mobile phone standards in the past, probably the most boring topic you could imagine. And as mobile phones in the 90s and 2000s became this extraordinarily dominant technology, they spread faster than almost any other technology ever across nations and classes and so on. It was clear there was an enormous untapped potential to use them, not just for SMS and conversations, but also for other things. In the early part of the last decade, I was in many meetings trying to persuade the big mobile companies like Orange and Vodafone to mobilize that untapped potential. They were not very interested then. They were doing incredibly well commercially. And it was only later that much of that potential was realized, weirdly, often in places like East Africa, which pioneered mobile health and mobile monies and so on. And that's why we were so keen here at Nesta to see examples which were combining the best of the technology with real pressing needs and public services. And so when GoodSAM came along, this seemed like an ideal project to back. And we've been supporting GoodSAM, Mark and Ali and others for some time. Partly because it's at its core about integrating the best of a public service and paid professionals with voluntary help. It's making use of a ubiquitous technology. It's been smart, as you'll hear, in adding on other technical features. It's been, I think, very smart in thinking through the practical risk issues. There is risk involved in any innovation of this kind, but they've been very well managed. And crucially, and quite unusually for innovations in this space, it's been designed really from the start to be scalable, very scalable at low cost. So our hope is that GoodSAM will go from strength to strength, will save many lives, but also I think will embed even more in, I guess, in all of us that sense that a really healthy health service is one which has fantastically motivated and committed and professionals, but also one where others are contributing as well, giving something back into the system as well as taking out. So I hope you enjoy this evening. I hope those of you who aren't already completely committed converts become converts, and GoodSAM goes from strength to strength. Thank you. Christine, over to you.
Hello, good evening, and very warm welcome to Nesta. My name's Christina Cornwell. I'm a director in Nesta's Health Lab. My team and I have the great privilege of working very closely with GoodSAM and the team and many other fantastic health innovators. So we're really glad to be supporting this evening. You'll see we've got a jam-packed agenda for you tonight. I think we've got 11 speakers in 90 minutes, which has smashed any record for Nesta, and possibly will be the last time we have that many, but we'll see. So my job really tonight is just to make sure we keep to time, that you get to hear from all of the fantastic speakers that we've got, and that there's also time for all of you to engage and ask questions as well. So just to quickly give you an overview, we've divided the evening into 3 parts. The first is really about setting the scene. So it's about understanding the kind of current and future demands on emergency services, thinking a bit about the way that new approaches to data and technology are creating new opportunities, and also to get an introduction to GoodSAM. In the second part, we're going to dive into the detail of how GoodSAM is working with ambulance services to really help them to react more quickly and more effectively to cardiac arrests. And in the third section, we're going to be exploring some of the new opportunities in technology, with a particular focus on video triage and about supporting older people living at home in their communities. So there'll be opportunities for questions and answers in each of those parts. I will be asking all of you in the audience and the speakers to keep questions and answers short and clear and as to the point as you possibly can, so that we can get through as much as we can. So without further ado, let's move into the first part. I'm going to introduce all of the three first speakers together, and then they'll come up one at a time, speak, and then join me on the panel. We could probably fill 90 minutes with the credentials of the first three speakers, so I've had to choose some edited highlights for you. First of all, we'll hear from Professor Keith Willett, Director for Acute Care at NHS England and Professor of Orthopaedic Trauma Surgery at University of Oxford. We'll then hear from Dr. Simon Eccles, Chief Clinical Information Officer for NHS England and NHS Improvement, who's also a consultant in emergency medicine at St Thomas's here in London. And then from Professor Mark Wilson, who's co-founder of GoodSAM, consultant neurosurgeon, air ambulance doctor, and Professor of Brain Injury at Imperial College. So to kick off, please join us, Keith. Thank you.
Well, good evening. Thank you very much. And we'll cut straight to the chase because I've literally got 5 minutes. So a big change is going on and we're behind the curve. So medicine is changing. What I used to do in the resus room as a trauma surgeon, the paramedics now do at the scene. The population's changed. We have a right now society. People expect to be able to buy things, get things immediately, even if they're not urgent. And so they expect the same response from healthcare. And our patients have fundamentally changed. They've gone from presenting with single system illness or injury to now having very complex problems and care. So we've got to dramatically change the way the urgent emergency care system is delivered in the NHS. And that's the process I've been leading over the last 5 years. And it's difficult, but we've made some really big changes and they're ongoing despite the difficult financial and operational times we've had in the NHS. So let me give you some examples and how the technology and the wider technology like GoodSAM will start to feed into that. The fundamental behind the urgent emergency care review, the principle is that we need to deliver care that's personalised and effective as close to the patient or in the patient's home as possible. So what does that mean? It means we've now got to break the NHS from what's been a hospital-based system out to the patient. We've got to provide bystanders or clinicians at the scene decision support, local information quickly so they can make the right decisions. If there's diagnostic information, they may need help with the interpretation of that. And then we need to help coordinate that care. So how does the NHS now start to change to do that? Well, some of the biggest changes we've made around the 111 service. The worst thing in the world, isn't it? Terrible, awful, clunky, doesn't work, rubbish. Every year, millions of more patients are using it. We've gone from 4 million to 16 million users over a matter of a few years. It might not be the best thing in the world, but it's certainly doing what the public want, that right now response. So we've changed the 111 system from being a signposting service. So we've now built behind it a clinical advisory service with GPs, paramedics, pharmacists, mental health teams. So more than 50% of patients now get put through to a clinician and don't just get signposted, they get what they need there and then or booked directly in to the right service. We have just fundamentally, over the winter, despite the pressures, changed the whole way ambulance services respond. We've actually changed the national standards. Going into last winter, 55% of ambulances were responding on an 8-minute target time. Less than probably 1% would clinically have benefited from a response that fast. But we have ambulances and crews driving on blue lights, trying to compete to get to a patient just to stop the clock in 8 minutes. We've changed all of that now, so the ambulance service now works to a different set of standards, and we've gone from one ambulance serving meeting one of the standards last year to now the majority of our services meeting all the new standards, which is really impressive, which means now the patient gets the right clinical person and the right vehicle for the problem they have. And then behind that, there's the technology and the expertise to support decision making. So that's how the NHS is changing. Really massive. We aren't on a journey because the journey's too slow. The system's changing bigger than that. It's, if you like, accelerated Darwinism. And the truth is, if we don't evolve as quickly as the system is asking us to, then the NHS will not survive. Thank you.
contemplating a Darwinian reference, but I'll avoid it for the moment. I'm Simon Eccles. I'm the Chief Clinical Information Officer for Health and Care, which is a slightly curious job title, but I'm basically National Director for IT for the NHS, as we heard, a doctor by background. The NHS, NHS England, Department of Health, has a pretty central role in some of the ways we help disseminate new technology. If we get it wrong, we also have a pretty fundamental role in restricting the ability for the NHS to adopt new technology, and it's a bloody fine line. You've heard the pressure on personalised care, which I think is very important, very real, and we've got a tremendous drive to try and help people use digital tools that they are happy to use in almost every other aspect of their life, but are relatively challenging to use in the healthcare environment. So a number of things to do for that. Our role at the centre is primarily enabling, I'll come on to that in a moment, an element of light touch regulation, and we need some regulation. Remember the adage, if on the internet, whatever you are looking at is free, you are the product that is being bought and sold. Cambridge Analytica can provide you with high details on that, your own details probably. And we've got a role around dissemination. Any of you involved in the app space anywhere in the NHS, you make a successful sale or a successful pitch for a digital tool to one NHS organisation, you bound along to the next one going, look, they're using it over there. And they go, we don't care. We want our own pilot. We're going to start again. Yes, nodding at the... we are hopeless at this. So we set up health innovation networks and others to help disseminate best practice to allow small and medium-sized enterprises, and a real emphasis on this, because the best innovation we're going to see is going to come out of tiny companies. 2 or 3 clinicians and a couple of coders coming up with something that will change the NHS. The other bit are some big enabling functions for us. So we've got to get the data free of the systems in which it's held. Thank you very much. Subtly done. Data free of the systems in which it's held so that everybody, with patient's permission, can use it as and where appropriate. Assured identity. We are quite familiar with the concept of assured identity on our mobile phones for many other functions. Banking, travel. You can book yourself an airline ticket, check yourself in online, and using a Q code, get through security gates. But heaven help you if you try and look at your own medical record online, because it's simply not available. And what I get back is, but health data must be held to a much higher standard than terrorism. We've got ourselves muddled here. So assured identity of staff, assured identity of the citizen, linked if required to a device, with an appropriate security layer that means they trust the ability to download their personal health information to that and share it as they feel appropriate. Or to have that held somewhere centrally and used on their behalf. The summary care record is the best example. 98% of the population have their medications on the summary care record, and about 20% of the population have chosen to have an enhanced summary care record with more details. We need to make that available to ambulance crews on their way to treat people. That is challenging, but it needs to happen. We need to provide the right infrastructure to allow observations and other details to move quickly from one place to another in order to be assessed, so that eventually we get to a world in which a crew on their way to treat someone is, thank you Mark, to GoodSAM, seeing the individual or hearing appropriate details about them, can pull down that person's health information as and if that is appropriate, and then send everything they need on to the receiving hospital in advance of the individual arriving so that they are ready to receive them. We are a long way off that at the moment. And I posed a challenge years ago when you and I first met, about 10 years ago. We were playing with this. If you imagine a few fundamentals, everybody in the country, 90, whatever it is, 1%, are geolocated all the time and personally identifiable for that geolocation all the time, and we can add their health records to it, and you can record their observations using devices that will cost pennies, and we have almost unlimited storage. What app can you build to improve people's healthcare off the back of that, and how do we help you do it? Thanks.
Thank you very much. Thank you everyone for coming, first of all. And I've been given the task of giving 5 years worth of work in 5 minutes. So I'm sorry that Nesta were appalled when I submitted 20 slides. So I'm going to go through things pretty quickly. We've got a mission, really, which is our ethos, which is to save lives by using technology. That's a combination of creating communities and using really advanced technology to empower those communities to save lives. And this really came about principally because of impact brain apnea. So I'm sure the clinicians in the room know what I'm talking about, which is where people get a whack on the head and they stop breathing. And we wanted to find a way of empowering people to be able to hold people's airways open. But actually, there's a much bigger need, and this is where we started out in cardiac arrest land. And in hospitals, about 50% of people survive cardiac arrest, but most of them are pretty sick. On the streets of London, I don't need to tell this audience, but it's about 9% survive cardiac arrest. But in Heathrow Airport, it's around 80%. And that's because there's an AED at every other gate, and the sick cabin crew are trained in CPR. And what our initial sort of mission was to try and recreate the survival in Heathrow Airport on the streets of London and the rest of the world by using technology. And that's where it all came about. And like they say, you're never more than 5 meters from a spider. You're probably never more than a few hundred meters from someone who can do CPR. So doctors, nurses, paramedics, policemen, firemen, first aiders, people who are trained. And that's where it really came from. And that community has now massively grown. So 40,000 people all around the world, and it's integrated in ambulance services across New Zealand, in parts of Australia, across the UK and other parts of the world. And I'm not going to have time to go through some of the other stuff in terms of resource-poor environments where it's acting where there isn't an ambulance service. But that gives you an idea of the responder density across London, and it's always increasing as we get more partner organisations on board. We are really lucky that we work with some amazing organisations. Some of them are on this slide here. There are more than this now. We've been brilliantly lucky to be supported by Nesta and the Resuscitation Council and other organisations who have helped us grow over that relatively short period of time. There's a lot to go through, and I'm not going to have a chance to go through it all now, but I want to really emphasise that our two core things are governance and security, and then innovation and collaboration on top of that. But governance and security are really important. So some of the new things we're doing, which we've brought out, really give ambulance services complete control. For example, they can upload KML maps and have different response radiuses for different areas, who they're alerting. It is extremely flexible. We're building a community all the time, and so one of the other new features you may have seen is the fact it's got a two-way radio in the system, and actually people are using this now to keep in touch with their colleagues, and it's a nice way of keeping the community alive. The system also works on silent, which has been another big work that we had to complete to get that through on both Android and Apple. We do lots of other things. Map AEDs. It's the world's largest AED registry by a long way. We believe AED data belongs to ambulance services, so we give that data to the ambulance services, and the ones we work with sync it back to us, which has been fantastic. Over 40,000 AEDs mapped. We've now released this AED Tracker tool, so that actually, one of the problems was that lots of people didn't know where all the other AEDs were. Well, the static AEDs, which we've mapped, but we knew where they were. Most of them in the back boots of people's cars, as everyone here knows that's where they were. So now we've got a system whereby you can say, I've got an AED on me. So in addition to the 40,000 AEDs that are mapped, we've added many more thousands that people are carrying with them. And for example, in London, there's about 900 police cars with AEDs on. There's taxi services, I think people here tonight, that carry AEDs as well. And we now have an ability to have the infrastructure to map those. And there's drone stuff, which I haven't got time to talk about drones, but everyone loves drones. We've got a brilliant system. We've got 40,000 people who can look after drones. So there's a whole world of piloting drones and people being able to say it's safe for it to land. We've got the infrastructure to make that happen in a governed way, make sure the drone is packed up safely and flies off away. Because we've got a really good network of good people, this is all possible. And this is stuff we're working on now. That's not England, but but in Australia and other places as well. There's lots more. I'm not going to have time. There's a booklet you can have a look at, but CFR dispatch, major incident management, because you can see where all your staff are, co-responding, cross-services platform. There's tons of stuff that comes on all this. And in the last couple of minutes, I just wanted to talk about the direction of travel, and Keith and Simon have both said this, and I think we're in a really exciting time. This is the music industry over the last 100 years, gone from wax cylinders, records, to tapes and CDs, and the pre-hospital care industry has gone from stretchers with wheels, horses, and then ambulances. Somewhere in there, telephone was invented. That was a pretty big deal. I don't think central ambulance control was very busy before telephone was invented. But the next stage is video and digital. And the helicopters, everyone loves helicopters, but as I say, everything's gone over to digital for music. You don't go to Woolworths anymore, or it doesn't exist. You don't go to buy your CDs. And we can provide so much more through our ability to see. And I think you're going to have this ability to triage according to scene, how big's the fire, how many cars are involved, and triage by patient as well. And I think this could be really fundamental and to a degree similar to the advent of the telephone, because we can start providing care before we even arrive, not just sort of diagnosing, but actually providing that care by encouraging people to do CPR, hold an airway open, run that burn under the tap, all those kinds of in a more controlled way. We're going to do a little demonstration if I have another minute still, in a minute, just to see if it just demonstrate how that system works. But that kind of shows you the dashboard that you see. And we're really always innovating. So this video system enables us to open up anyone's mobile phone. There's no app that you can just send a text to a number and they get a link, they click on the link, it opens up their cameras with their permission, shares their location data and their camera data, and we can either measure people's pulse directly through that, just from the camera itself. Not by putting your finger over the camera, but actually just by looking at the face. And I'll demonstrate that in a couple of seconds. The other thing you're going to hear about later on tonight is from St John, and we're really trying to work with the third sector to encourage the other burdening area within NHS world, which is the vulnerable and elderly care issues. Keeping people at home is a really big deal. Certainly I see it in my NHS world of head injury. And whilst we can make people, we can alert people to see for cardiac arrest, we can also alert people who can put Doris back in the chair, make a nice cup of tea, and then really get a response if required. And I think that's a fairly big thing. The last thing, we've got a really small team, but it's a really great team. There's Ali Haddad here, who's one of the co-founders, Ali Gorbongoli, who's at the back there, who is the pretty one, and also the tech genius behind all this. And these are some of this Deepsy's our project manager, and the rest of the team, both here in the UK and Australia. So we want to thank everyone who engages with us. Have I got time to do the quick demo? Yeah? Thank you very much. So we're going to send a text now to Richard's phone here. So this is the GoodSAM dashboard. And he's just sent a text from the back there. This is all very fast. Just type in the number. So Richard should receive a text any second. And on it, it will say, GoodSAM is trying to, well, we can have it whatever you want it to say, but can you click the link? If he clicks the link, it will say, are you okay to share your location data and your video data? And if he says yes to both of those two things, it should, this is a real Bill Gates moment, isn't it? It should open up the camera on his phone, and you can probably see it's putting a little red box around his face, and that's just basically measuring his pulse. So I think it's 57 at the moment. And that's just using the colour changes in his skin and a few other clever techniques to measure pulse remotely. We can also do multiple people at the same time and respiratory rate and other things. But this is where we think you can get objective measures as well as being able to see a patient, which can help you in terms of, or in the future, help us in terms of triage and other things. But I'll let Richard talk a bit more about video later on. Thank you very much. Should I sit next to you or should I sit next to you?
Thank you so much, everyone. You've packed in an amazing amount of information and provocation there in your short talk, so thank you. So we've got about 10 minutes now for some questions from the audience. We've got 2 roving mics. We should have 2 roving mics. We've got Becky there. Have we got any other mics? Is it just you, Becky?
Just me.
So have we got any questions? We've got one at the front.
Oh, yeah, thank you.
Right, so I'm Mark. You got it?
Yeah. Hi. This technology can be actually used for quite a few other things. It could be used for diabetes as well, similar kind of, because it was, I think it's already running in Scandinavia somewhere, did something like this. And for diabetes, so we can this can be done on that, and also I think there's a lot of the health things can be more than likely be run. Just need to change a little bit of the program.
Yeah, I think that's very true.
Great, thank you. Can we collect some other comments and questions? Yes, there's a lady over here, please. And gentleman over here as well. They're funny, these mics. If you make sure you speak into the black circle,
I've
thanks.
met them before.
Great.
Hi there. I mean, this question, I suppose it's pointed at Simon, but I'm interested in what the rest of the panel think. One of the problems that I've identified working in health technology is not just different standards with devices and platforms, but different standards in measuring things like pain or severity of injury or working with patients who can't communicate very well and trying to find biomarkers or metrics. And I'd be interested to find out whether the NHS are looking at any kind of standardisation of these kinds of things, or... Thank you.
Great, thank you. And one over here.
Mark, hi. I work with Hampshire and Isle of Wight Air Ambulance. I'm particularly interested in the scene camera app there. Obviously, we're quite rural. Am I right? I'm assuming it relies on 3G or 4G signal. And if so, like with other 999 calls, are you able to utilise different providers' signals? Is there a way of circumventing your own individual provider?
So I think probably best to address other questions towards these guys, because I'm going to be around later on as well, and you're going to get more on video in a little bit. But specifically regarding that, so yes, it does need a data signal, but that could be Wi-Fi, which a lot of people have in their house as well, even if they haven't necessarily got a good data signal there. And currently it will work through whatever provider you're with. Most people will choose a provider that works where they live. You'll take the phone back if it doesn't work. You see what I mean? So actually, it kind of resolves
it's
itself.
more than the non-domestic side of things.
Yeah, and I agree. Currently, although we have systems for the GoodSAM cardiac side of stuff that works when there's no data, for video, you kind of need the data.
Great, thank you. Jumping in.
Oh, sorry.
Apologies, I forgot to ask people to say their names and where they work, so I'll make sure I do that next time. We've got the other two questions about uses with other clinical diagnostic conditions like diabetes, and also the question about different standards. Simon, you look ready.
Shall I grab standards? The answer to your question is yes, in that we need to set standards that can then be reproduced and understood by everybody. So what we're after here is an open standard that can be interpreted by anyone who is designing software for any clinical determinant that has a clinical standard behind it. And I say that because it becomes very, very tricky when there isn't a clinical agreement on what you're talking about. But for basic physiological observations, for routine pathology testing, for age, for dates and so on, just dates for 2 seconds. If you've booked anything online recently that involved booking a time and a date, you will have been offered the opportunity to incorporate that in your calendar. And the system you're on will determine whether your calendar is Microsoft or Android or Apple, and will slot it in for you. Health, we send you a letter to pin to your fridge, which in the case if you've got a long-term condition, my son has, maybe a year in advance. You are relying on strong fridge magnets. We are so far behind where we need to get to. But yes, we have a programme to standardise the things we can.
Great, thank you. And Keith, would you like to come in?
Yeah, so on the other areas of health we can use this in, I think this is where we get into slightly wider technologies. I mean, but we are now swapping what used to be big pathology labs and massive PCR machines for things that fit inside a GP's bag, let alone on an ambulance. So I was at a conference yesterday, point of care testing for flu and respiratory viruses. Little box, this size, you can do it. It's massive influence. Doesn't mean you've got to transfer the patient to hospital if you can identify they've got flu. If they get to hospital, you can move them through. The bit that's going to be difficult with this technology is saying, yes, we can do the technology, but how do we use that best in the operating model that the NHS is operating for the pathway of care? And how do we change the clinician's behaviour, not to just start doing loads more tests because it's easy, and then working out we're over-treating patients. So there's a real challenge in here to land this right, and there's a danger we accelerate into technology and don't deal with the operational and the behavioural issues that need to follow.
Great, thank you. Mark, did you want to add anything on that?
I thought I'd used my question. No, I think there's masses on this. I mean, we always seem to find new areas of need. I haven't mentioned stuff like working in resource-poor parts of the world where there is no ambulance service, but in parts of Brazil, India, and Africa, both the sort of GoodSAM alerting system from a point of view of alerting people who are good at first aid for road traffic collisions is there, but also the video side of stuff is just huge because it's a long way for people to walk to go to a hospital. Actually, you can follow up their wounds and all those kind of things. So the technology offers itself to, and way more outside of health as well, but for police and fire and other things as well.
Great, thank you. Let's take another couple of questions if we've got some. Is anyone else? Two hands over there. If you could say your name and, if relevant, where you work, that'd be great. Thanks.
Hi, I'm Nick from Northwest Ambulance. The question's probably directed towards Simon. We're just at the moment piloting a clinical portal system for clinicians in the control room, which will be made available on the tablet devices going out onto vehicles. But the problem that we're going to face is signing up hundreds of GP practices via CCGs. So as you kind of mentioned, is there any plan to sort of make that a lot simpler, as in just click a button and we agree to use that in the correct way, and the patients that have said that they will share that information, it can just happen?
That's great, thank you. And can we take the other one as well at the same time?
Hello, my name is Yannis Zagerman. I'm a student at a master's student at UCL. I'm also I have an organization in Brazil who's using GoodSAM, a little bit of the system. I would like to know how the NHS is perceiving volunteers in the use with the GoodSAM here. How important are volunteers in using the system here, and how is the NHS dealing with the legal issues in using volunteers, if there was any problem with that, and how can other countries blind themselves with that?
Great, thank you. So great questions there. Who wants to jump in first? Well, the one about data sharing with other partners in the system, and then one about issues around NHS volunteers.
Fantastic. So I swear the question wasn't a plant, but yesterday we launched nationally local health and care record exemplars, which has been known by the acronym LICRA, which gives a slightly unpleasant image of middle-aged men running too fast and looking sweaty. But if you just ignore that for a second, longitudinal locally integrated healthcare records. That's the aim here. So it shouldn't be up to the ambulance trust to make its own connection with each GP practice and its own connection with each emergency department in its patch. We need to integrate the care records for a geography, roughly 3 to 5 million people, which works out at the referral pathway for a tertiary hospital. So a cancer referral pathway, a vascular referral pathway. Get that, even neurosurgery. Get that right. Integrate the records, make the data able to flow between them, get all of those permissions done once and centrally for that region, and you end up with something that is truly useful to patients receiving care and to the staff caring for them.
Could I just ask a follow-up on that? Does that include horizontal sharing for people that have got multiple conditions as well as to single clinical pathways?
Yes, indeed. So the aim is for the individual, you can see your own longitudinally integrated care record, and anybody who has either personally had cancer or had a relative with cancer will know, despite the fact you're on what they're describing as a coordinated pathway, the disjunct between each of the steps in that is profound. We are not good at this yet, so the aim is that that becomes clear and seamless.
Great, thank you.
It's going to take a day or two.
Mark, did you want to talk about the volunteers?
Yes, regarding volunteers and sort of the way it's worked in the UK and other places is there are lots of different levels of volunteer, or different types of people rather that volunteer, and the NHS from an ambulance perspective have been very welcoming in using that. So, for example, the CFR community that's been around for a long while has been fundamental to that. And what we're doing is providing a platform basically to build that community. And I think so long as it's governed in which always has our absolute core, then that works extremely well. I say there are so many different types of volunteering that it's very difficult to explain very quickly. But forget about the cardiac arrest side of stuff at the moment, but there's people looking after their next door neighbour, and we can use the system now to make sure that elderly care, people who are elderly or vulnerable can have volunteers access them very easily. So I think I'm sorry I'm not answering very well, but it's such a big area, but we'd be nuts not to be using our local community to provide some of the essential and basic levels of healthcare that we have.
Thank you. Very quickly, Keith, if you want to do this.
I was just going to say that's absolutely right. I mean, where volunteers are part of a major organisation, St John or Red Cross, then clearly police checks have been done and there is a contractual arrangement with the NHS and the ambulance service. Likewise, with the community first responders, they've gone through a programme and therefore there is a governance structure. I mean, quite clearly, this is a legal area that will develop because nobody's going to turn down the Good Samaritan action of a bystander, but once they are being initiated by an organisation, even if it's through an app, then I think that's probably a legal area that I don't know has been tested. Perhaps the ambulance service, when they talk later on, can address that.
Fantastic. Thank you very much. We've run out of time for this bit, so thank you very much to all our speakers. Thank you. So we're now going to hear a little bit more about how two emergency services have been working with GoodSAM to integrate their work into how they respond to cardiac arrests. First, we're delighted that Mike Ray has been able to join us from Emergency Co-Responder Programme for Ambulance Victoria in Australia. And then we're also delighted, although he's come less far, to have Neil White, Transformation Delivery Manager from East Midlands Ambulance Services. Please come up. I don't know where you are, actually. Where are you? Here, Mike. Hi.
Thank you. Yes, as you say, I'm across from the colonies. Got 7 minutes, and I think I actually spent longer talking to the immigration officer at Customs. Had a lot of questions about what GoodSAM was and how it worked. Maybe that was because I was looked suspect coming off the plane, but anyway. So yes, talking about Victoria, it is a population of about 6.2 million people. Most of those live in the capital city, Melbourne. We cover an area of just over 250,000 square kilometres with one ambulance service. So in terms of perspective, that's largely about the size of Great Britain. We do it with one ambulance service, so we cover quite a disparity between very populated urban centres through to quite regional and remote locations. In terms of workload, that sees about 800,000 cases per year, and about 6,000 of those are cardiac arrests, so reasonably high numbers. It takes a system to save a life, and I think this is really important. You know, GoodSAM is one component, and a very important component, but it really is about the system that you integrate right through from, we have, as I'm sure you do, 000 call is an integrated health system. But call taker instructed chest compressions. Our call takers will quite forcefully on occasions instruct people how to undertake chest compressions. We have a public access defibrillation program and an AED register, which I'll talk about in a moment. We have community first responder teams. We have two-tier ambulance response. We have specialist retrieval services, all those types of good things. In terms of the public access defibrillation program, so we have an AED register, which is one centralised for the state. It is managed by ambulance. The better the opportunity is to identify one when you need it in an emergency. So what we've done in this space with our registration portal, and I think this is really key, is to move from having a one-way warranty card style registration through to about them in the registry, and importantly they can update that information, and we require them to do that every 12 months or so. As part of that, we've undertaken a fairly major media push, and there's some examples of the collateral that are up there in online, social media, and then really key, I think, are those partnerships with organisations, your manufacturers, your retailers, those types of things. So there's information about AED registration that we include at the point of sale, at the point where people are most motivated to take action and registration. In terms of a process, so it is all driven and integrated off our 000, which is our national emergency service number for police, fire and ambulance. You go through a structured call taking process, and we use AMPDS and the ProQA systems in Victoria. If it's one of the 6 event types that we've selected, there's a few things that happen. Firstly, you'll be instructed how to undertake chest compressions. Secondly, the emergency services dispatch happens automatically. And then thirdly, in the background, we've got the GoodSAM system, which is activated automatically. Really important, the governance processes, and we've gone for an automated system that's based on the AMPDS event type. So if the case starts as an unconscious fainting and is upgraded to a cardiac arrest, the GoodSAM system is alerted at that point. Similarly, if it's downgraded to a stub toe, GoodSAM is cancelled. And part of that as well, we've gone for a system with a whole lot of automated search algorithms. So things like inappropriate locations, and we have controlled facilities, defence facilities, police stations, GP clinics, nursing homes, all those types of things. We will not send a GoodSAM response to those locations. Similarly, location of interest, which is our violent people, places where we wouldn't send an ambulance without police support. We're not going to send community responders into those locations. Inappropriate patients centres around advanced care directives, not for resuscitation orders, people in palliative care. We don't want to be sending community responders to them. They've made a decision about what their advanced care plans look like. And then anything with a scene safety or occupational violence filter. So mental health, alcohol and other drugs, anything with uncooperative callers on scenes. We preemptively won't send our community responders into those sorts of locations. So we've undertaken a staged introduction. We've started with our operational workforce. We did that in about January, and since then we've seen about 1,100 people sign up, and we're growing that with our partner organisations. You can see up on the board there, Fire Service, Lifesaving Victoria and a couple of others. So we're growing that responder cohort through that partnership type model. And the other place that we're getting people from are the registered health professionals. So similarly to what you have in the UK, we have a national registering body, and we're accepting all registrations from anyone that's a registered health professional. In terms of recruitment, and this again has been really key for us, having the support of a media team or a communications team, we've developed a lot of collateral, and I'll show you a short video in a moment, to help try and drive that responder awareness and the recruitment that comes off the back of that. Cool. The other couple of things, and this is quite a busy slide, but in terms of the governance, we've come at it from the perspective that this is a chain of survival. It's part of a network of, right from the first person to arrive and see the patient who makes that 999 or 000 call, right through to the advanced life support that occurs at hospital. It needs to be an integrated system. So in terms of responder welfare and follow-up, we do telephone-based follow-up of all of our responders. 3 things. Firstly, thank you. Secondly, do you have any questions? And thirdly, are you okay? And if the answer's to that no, then we can refer them back to community support mechanisms. We have a connected health system in terms of AED data retrieval. We'd go out, try and get the data off the DFib and get it to the hospital, and that has an impact potentially on the way or the pathway that the patient takes through the hospital. We also have a lot of reporting, so the Victorian Ambulance Cardiac Arrest Registry, every cardiac arrest that we see in ambulance goes into this registry, and we report on that back to our community, and you can see some examples of the reports that we get up there out of the GoodSAM program. So I suppose very quickly to summarise some of the key lessons for us is that you will get public interest out of a program like this, and you should really capitalise on it. The community education about AED registration, the importance of it, the importance of community CPR is really key, so that component is very significant. Responder awareness and engagement is crucial. The integration component is really key. To give you an example, the speed of the GoodSAM system coming out of our CAD will often beat the ambulance dispatch. We've had cases of on-shift paramedics that will get notified via GoodSAM before their pager or their radio will go off. So the integration and the automation is absolutely key. And then at the last point, you really can't improve on what you don't measure, so reporting. Now, have I got a minute and a half? Can we play that? This is just a very short video that we've used to help drive responder recruitment.
It was half time.
I walked around the gym for a little bit.
I was playing soccer.
My legs just gave out from under me.
I felt really dizzy.
And collapsed.
I was unresponsive.
And I had no pulse.
I had a cardiac arrest.
Luckily, a couple of my teammates knew what to do.
Someone got a defib.
The guy started CPR.
The defibrillator restarted my heart.
When someone is in cardiac arrest, every second counts. The sooner somebody receives CPR and defibrillation, the greater their chance of survival. Saving lives is always a team effort. That's why we've partnered with GoodSAM. It's an app that alerts off-duty professionals like you to cardiac arrests nearby. If you're a medical professional or qualified first aider, please join us. Register as a trusted GoodSAM responder today.
If those guys hadn't been there, or if they hadn't been able to get a defib, I wouldn't have survived.
And it just goes to show the power of being able to dynamically crowdsource a team and integrate them into a system of care.
Thank you. It's very powerful, that video. Neil, would you like to join us?
So good evening everyone, I'm Neil White from East Midlands Ambulance Service, and I'm going to talk about our 2-year journey today of where we came from in terms of using the GoodSAM app, how it's benefiting our patients and what it's done for mobilising social impact across the East Midlands. And we started this journey 2 years ago, meeting Mark at a conference where he presented this idea, and at the time we were looking at our cardiac arrest strategy and we were saying we have a 10% chance that patients will survive in the community and we need to change that. And one of the areas that we can change is the time that we start CPR from the moment the patient calls 999 until the ambulance service arrives. So in our organisation, we have a bright ideas process, and this helps set the scene about some of the issues that we faced and some of the contact that we have from our ambulance services across the UK, because essentially what we did was take an app we found on the App Store, we gathered our IT teams together, and then we set a story. And that story was we wanted to connect this app to our command and control systems, part of the UK's critical national infrastructure, take the patient details, broadcast them through an open API across the UK to the nearest 5 responders, some of whom may not have DBS checks, some of them may do, in the hope that they then go and start life-saving treatments for patients. And that idea in the NHS, when we talk about clinical governance and we talk about information security, was quite hard for an organisation to come to terms with. And I was trying to think of the best way to describe the first 6 project meetings in getting the organisation together. And that's kind of what it felt like, because we were doing something that, as an NHS, we've not done before. We have everybody having DBS checks. We make sure they go through rigorous training programmes. And what we needed to do was set up an approach that said we're having good governance, not governance because people's opinions block transformation and change. And we did that using the GoodSAM feature. We make sure everybody is registered appropriately. We make sure they have the right qualifications. And then, as Mike explained, we used automation and make sure that the right calls go out to the right responders at the right time to keep patients safe. And that was the mantra that we use, that CPR is absolutely critical to this. We need to start CPR soon. We need to make sure the patient has the best chance of survival. We use a partnership approach, and we work with organisations rather than trying to register all of the volunteers and impacted people at once ourselves. And we've built up a network of around 1,600 responders across the East Midlands, and that shows the footprint. The green are those that respond with East Midlands Ambulance Service. The red are the partner agencies that we work with. And since we launched in June last year, we have around 16,000 alerts issued, and we have 30 patients who have had a return of spontaneous circulation and have made it through to hospital alive. And we are aware of 2 patients that have survived to discharge through CPR starting almost immediately from the 999 call being made. And that shows the high-level impact on a page of the benefit that this is happening. And the middle sentence is really key here. The average response time in the East Midlands for a double-crewed ambulance is around 8.5 minutes. At 4 minutes, the chance of survival is almost negligible without CPR and without prompt treatment. With the GoodSAM application, we're seeing healthcare professional, high-quality CPR being performed in an average of 3 minutes and 47 seconds. The benefit of this app and the global nature it has, our responders and our staff are attending patients outside of the UK as well, providing care to those patients immediately. It's had a real benefit for us as an organisation in making a step change to our staff to show that we're improving patient care. We've had high levels of demand, we've had prolonged waits, we've had clinical issues that we need to address, and we need to think differently about how we respond to those patients. And our staff have taken to the app and they use social media regularly and they track their change. And really it's forced them to change their practice, as you can see from the second tweet down there, running into a restaurant dressed in joggers, ready to start CPR. It's how you introduce yourself, how you set the scene. Moving forward, we've realised that this technology is a real game changer in emergency care, and we've talked about the video triage, and the police forces have come on board with us to say we can work collaboratively to share the demand issues that we face. We can provide clinical support to the police officers, and we can minimise the number of emergency services that are attending scenes. We can work together, and we can use that technology effectively. But more so, beyond clinical care and through Department of Digital Culture, Media and Sports strategy, we want to be able to mobilise social action throughout the ambulance service. And in the UK, at the moment, the only way to volunteer is as a community first responder. And in the winter, we saw lots of requests from the public saying we've got 4x4 vehicles, we want to help, we want to get to staff, we want to get to patients. Using this technology, we can mobilise that social action far more effectively than we can with our traditional means. I haven't got a video to show you about a patient story. What I have got is this single tweet here. And I said when we started this journey and we faced the clinical governance and we faced the information security, just one patient, just one life saved would make all of that pain worthwhile. And here we have a patient reunion where the patient has survived thanks to the technology, thanks to the quick CPR, and thanks to people giving up their time to respond.
Brilliant. Thank you so much. Now, we're hoping that Fiona Moore is here to join us. Is she a couple of minutes away? Well, she can perhaps join us at the last session. We are going to be joined by Ali Gorbangoli, who's the other co-founder of GoodSAM and the technical director. Thanks, Ali. I don't want to put you on the spot while you're still running to the stage, but it'd be great to hear from you a bit about how you found the experience of trying to integrate this new technology into ambulance services that, I don't know, perhaps haven't been used to using a lot of innovative technology. I don't know if that's true.
That's a very good question, and I would say the experience varies quite a lot based on where we start and where we are now. Because if you're going back in time 2-3 years ago, when we had no ambulance service integrated and we were just starting with London, it was quite difficult. Everything that we were doing was against whatever they were told not to do. Basically, it took us a while, but we will be forever thankful to London because they really championed the idea of integrating this sort of technology into their CAT. From that point onward, it became mostly easier and easier. And the reason for that was because it was battle tested, so people knew it was working. And we also got better as an organization, as a startup. We learned new things, we learned new tricks, and we improved the platform, so it was easier and easier to integrate.
That's great, thank you. Well, let's open it up again to the audience. We'll have the two mics going round. Would anyone like to ask any questions? Sure, somebody wants to. There's one there. If you could say your name and where you work, please, that'd be great.
Alec Robertson, member of a trust. Really a question. Obviously, having nobody there is really bad news. Is there a case where too many people turn up and they fight over who's got most authority to save a life?
So I think in the GoodSAM portal is completely configurable from radiuses right down to the number of people, and you can set that from 1, 5, 15 to 20. We chose 5, the reason that there would be enough people to go and get a defib to start CPR, and at one incident just last week, we had enough GoodSAM responders at the scene to start pit crew resus, where they were interchanging with each other and taking over. So it's really down to the individual organisational level that they feel comfortable about how many people they're alerting. We see sort of a 50% take-up typically of the alerts. So the more you send out, the more chance you've got somebody to get to the scene.
Great. Have we got some more questions? We'll take a couple if possible. One here at the front.
Lucy Will's autonomy project. I was very taken by both how instantaneous the support can be, but also how important it is to ensure the safety of the volunteers. But at the same time, if you've got people who are uncooperative, it could be because they're substance abusers or they have other issues. But there have been significant cases around the world where it's people actually with learning differences or learning difficulties who are actually having a panic attack because they're having a medical emergency, or they may be unsupported in the community. And I'm just wondering whether it's possible that, as well as having SAM services for cardiac emergencies and for other kind of really physical health issues, whether there's a possibility to have mental mental health and kind of where people go into shock or have sort of things that don't really fit into any of those categories, but they might need urgent, really, really urgent support and care.
Yeah, great question. Thank you. Can we take another one before we answer? I can see a hand there. So it's very hard to see from the front.
Hello, Sam Thomas from the Health Foundation. You mentioned some of the challenges of getting people who are looking after information governance and clinical governance on side. I'm interested from both of your perspectives, what won the argument when you were trying to have those discussions? What was it that persuaded them to go for it?
Great. Should we take one more? Anyone else want to ask a question? No? Okay, so we've got two great questions there. One about opportunities to expand it, particularly thinking about mental health, first aid as well, and first responding, and also about the governance and what won the argument. Who wants to take those questions first?
So I'll talk about the expansion. When we've implemented with cardiac arrest, we've come at it from quite a conservative point of view, and that's quite deliberate. We want to start with something that's conservative and potentially expand it from there. We, in terms of responders at the moment, also have a oversight within the communications centre that, for example, there might be an uncooperative caller that is uncooperative for a reason other than agitation. So our paramedics, duty managers and clinicians in the room can recognise that and override the automation. So there is that manual control. Equally, there could be something that we don't want to send people to that isn't picked up by the automatic filters, and they have that ability to override it as well. In terms of expanding to other case types, and you specifically mentioned mental health, I mean, that is absolutely something we can look at into the future, and it's something that we do intend to look at. There's other opportunities, and we've spoken about the video feature quite heavily in terms of secondary triage. So we have a fairly large cohort of callers that come through that aren't having a life-threatening emergency and don't need a lights and sirens ambulance response, but do need to be connected with the right healthcare service, and there are definitely opportunities in that space.
Thank you. Great. Neil, do you want to pick up the one about governance?
Absolutely. I think the nervousness around this is that it's new technology to the NHS, and when there's new technology, there's ideas for and against. And the argument that was put forth was really this technology is no different to hailing an Uber. You'll quite happily place a button on an app, you'll get into a car with a driver you don't know, and you'll go somewhere with them. And ultimately, the argument that we needed to get to was get executive team buy-in to say that it's about lives, it's about patients, and it's about patient care that really matters. And if it's just one life saved, as we said earlier, then that makes all the difference. And GoodSAM systems working, as Jeff said earlier, around small innovative teams, it's kudos to Ali and to Mark, because whenever there is a change, wherever there is a concern from an NHS trust, it can be changed within minutes. We can build new rules, we can build new skill sets and scopes to adjust to ease those concerns. Just on the mental health as well, I think from an ambulance service perspective in the UK, we need to move away from the traditional community first responder to where an opportunity where the community looks after their own health. And so through peer volunteering, through even just befriending until the ambulance arrives, because one of the unintended consequences of the ambulance response programme is that some patients with non-life-threatening needs are waiting longer than they would have done previously, and we need to be able to provide the right support, and we've got the video triage, but also just general support on the scene until the vehicles arrive.
Yeah, that's great. Thank you very much. Ali, did you want to add anything about the governance issue and how that sort of changed the way perhaps it was conceived at the beginning?
Yeah, I just wanted to add that one of the ethical, the way that we structure GoodSAM is two things. We are very ethical and we are very frugal. And that is really helpful when you're a startup in a sector that you have to innovate a lot. What that means for us is that we can have changes going out of our, from the moment of inception to the moment of implementation. We have had ideas that have been implemented in less than an hour. Comparing to a traditional IT company, that's impossible. And I think what gives us a hands up in terms of a startup in this sector is being frugal, being able to adapt to the environment that we face.
Great, thank you. We're pretty much out of time, so unless anyone's got a very burning, very quick question, I think we'll probably move on. So thanks very much indeed. So we're going to move on now to learning about some of GoodSAM's latest developments and explore some of the kind of newer opportunities for innovation in the sector. We're going to hear, first of all, from Professor Richard Lyon, who's a HEMS consultant and Director for Research for Kent, Surrey and Sussex Air Ambulance, and then from Professor Ian Greaves, Chief Medical Officer, and Alan Weir, Clinical Director, both from St John's Ambulance. So Richard, would you like to join us first?
Richard, and I'm an air ambulance doctor just down the road, based near Gatwick Airport. Is my clicker going to work? No.
Is it working?
Yeah. There we go. And we look after a population of about 4 million people across the southeast, out with the M25. But right now, about rush hour, that population's probably gone up to about 11 million people. And if you have the misfortune of living way out in the far east of Kent, you're actually closer to France in terms of advanced trauma healthcare than you are to London. You are a long way from help. And this is our bread and butter, car crashes. In this car, someone is trapped. It's going to take about 45 minutes to get them out of this car. It's going to take them another hour to drive them to hospital. This patient is likely to die in this car unless they receive really advanced care at the side of the road. They need the emergency department brought out to them. So this is why we use the helicopter. We use the helicopter with a doctor and a paramedic with advanced skills to get out to these patients as fast as we possibly can. Now, we are a charity. We need about £9 million a year just to survive. And we're always looking for ways we can improve care for these most critically injured patients. Patients like Harry. This was a child I went to a few months ago who had stepped out into this road and was struck at about 50 miles an hour by an oncoming car. Harry's 6 years old. He had a brain injury. He collapsed both lungs. He was bleeding to his spleen. He was bleeding to his liver. The odds of Harry surviving were absolutely stacked against him. And this is why we need to select out these cases where we can make a difference. And we can make a difference by bringing some really enhanced skills to the scene. So this doctor and paramedic are anaesthetizing a patient on the roadside. They're putting them into a medically induced coma. Critical if you have a brain injury like Harry or the patient you saw in the car. They carry blood. We were the first service in the UK to introduce pre-hospital lyophilized plasma, so we can give you not just the blood transfusion, but the one-to-one plasma blood transfusion that we know is good for saving life if you're bleeding. And in rare cases, we can do surgery. We can do open heart surgery on the side of the road. We can decompress chest. We can do all sorts of things that normally you could only do in an emergency department. But dispatch is crucial for us. Since you got up this morning, about 2,500 999 calls will have come in to the South East Coast Ambulance Service control room. Most of those are not going to be of the acuity that we need to go to. They're going to be standard stuff that the ambulance service deals with very well. We go to about 2,500 missions a year. We're busy. But our dispatcher needs to pick out those 4 or 5 cases where we can make a difference. Now, at the moment, that dispatcher, if they're lucky, they can listen in on the call. That's actually quite rare. They have to read information on a screen and try and decipher from what they're reading, which someone has typed in, whether it's an air ambulance job. Now, I'm going to show you a video, and just a health warning, it's quite distressing, all right? It's a real-life video of a case my service went to a little while ago, which I think just shows exactly the problem we're facing and why I think video from scene is an absolute must for emergency medical dispatch. So if we can play the video, watch carefully. Someone's crossed the road. They've been hit at speed, flung in the air, and look at the patient. They're lying motionless, almost certainly in this condition, traumatic brain apnea. Look at the impact that patient has sustained. Now, we never normally see this. and we wouldn't normally see this. It just so happens there's a CCTV on the corner. He's not breathing, he's not moving. Look at the reaction of the bystanders, or should I say, lack of reaction of the bystanders. They're in shock. No one knows what to do. This gentleman in the middle is now about to pull out his telephone. And we'll just go to the next slide. We're going to ask that gentleman some really difficult questions. Is he conscious? What does that mean to a layperson? Is he conscious? Is he not conscious? Is he breathing? Is he not? What injuries does he have? We really need to actually tell that bystander to open that guy's airway immediately if he has any chance of survival. He might even need some ventilation, some mouth-to-mouth. But without seeing that, it's very difficult not only to advise, but also to decide on whether we should send the air ambulance. So what we've adopted is this live from scene video streaming. We are asking the 999 caller to open their phone, just like you saw me and Mark do in the demo, and show us that patient, show us the scene, show us the car, to allow us to make a more informed decision about whether we commit that advanced pre-hospital resource. And you've seen from Mark that the technology is really exciting. If our team could see a patient's pulse rate, we could deliver that care much, much sooner. Someone who's got a very high pulse rate, like Harry, is likely to be bleeding. They're likely to be benefiting from that blood transfusion that we carry on the back of the helicopter. So we see this as really exciting in being able to pick out these patients not only more accurately, so we're not wasting valuable resource, but also much, much sooner. We don't need to wait for an ambulance on scene to give us a detailed report. We can launch, hopefully, within a matter of seconds, so that our teams can see it on the screen, we know exactly where they are, can get going, and we can deliver that advanced healthcare so patients like Harry, against all the odds, can make full recoveries from their injuries. Ladies and gentlemen, thanks very much for listening.
Great, thank you. Ian and Alan, do you want to come up? Is it working? You might need just to give a wave to the team at the back to get them to change your slides.
Any sign of a slide?
How are we doing? Can we get them back?
Abject darkness. Oh, well,
are you able to start? And we'll try and get them going.
We'll start anyway. You've heard all the high-powered technical stuff, and I'm sure you're thinking St John Ambulance here, a little bit like Corporal Godfrey with a little bag of bandages, doing lots of simple stuff. And in a way, that's true, but it's also a mistaken apprehension of St John Ambulance. And we're very keen to work with new technologies to increase the care that we provide, because we have some remarkable assets. We have the biggest ambulance vehicle fleet in the UK. We have over 1,000 vehicles. We have approaching 20,000 volunteers. And all those volunteers are CRB checked, or disclosure and barring as it now is, and all of them have first aid training, either at a basic or an advanced level. And St John, like a lot of other organisations, is in the process of transformation from an entirely first aid organisation into a much broader care organisation. And next year, we will be launching some new initiatives, of which we very much hope that GoodSAM, in one form or another, will be a key part. A key part of a multidisciplinary response, which will go from consultants in pre-hospital care, I won't say down to community first aiders, because I think that's patronising and it's also inappropriate, but to community first aiders, community first responders. And we are going to launch at some point in the new year a community health volunteer programme where we make the most of our greatest asset, which is our people, who are committed, keen, above all kind, and want to work within their community. And one of the drivers for this, I should say, for me as an A&E consultant, perhaps I should say emergency medicine, because my registrars get really cross if I call it A&E or casualty, is that we have an increasingly ageing population, we have social isolation, and we have a need to do something simple about some of these issues. And we feel at St John that we have the ultimate opportunity to do this and to produce solutions which are affordable for the greater health economy. I should say that the turnover of St John Ambulance last year was somewhere in 9 figures, so we're not talking about a small organisation here. But that is largely free to healthcare providers, and therefore gives us an opportunity to interact with both primary and secondary health care in a positive way. And our vision, therefore, is of community-based volunteers, probably going to be called community health volunteers, with embedded technological support, and that's why we're working very closely with GoodSAM, to provide a suite of services, essentially from social care to advanced medical intervention. But the key thing and the most important thing for tonight is the social care. We would like to be able to work to take patients home from emergency departments when their discharge might not otherwise be safe, to see them a couple of hours after discharge, to do trivial but important things like make sure they're safely in bed when they get home, make sure that somebody goes to see them at 9 o'clock the following morning, they've got some milk or some tea or coffee. All sounds really low-key, but it's important stuff, and we think we're in a position to do that. And because all our volunteers are healthcare trained, at least to some degree, they are also in a position to respond to what they find there in a semi-professional way and to take appropriate action if they feel that the person they are dealing with is sicker or less safe than they might otherwise think. And the aim, therefore, is to support secondary and primary care by easing discharge, also by preventing admission or A&E attendance, and to develop our range of community services by providing simple support to our enthusiastic volunteers. So I shall hand you over at that point to Alan.
And how can this help? Technology, not, as Ian says, something that we necessarily associate with St John Ambulance, but there are different ways and modes of getting in touch with us. A lot of people see this at our events, but in the context of this, that's not a way of doing it. We're not going to be sat in people's houses. We're not going to be sat there. So perhaps a sort of modern household assistant, the Alexa type help, forming a sort of way of calling for aid when you need it. Our strength is our people, and they are part of the communities within which they live. They can be there quickly. Our volunteers, we know, like to work within their communities, and they're there to support people that live and work amongst them. The beauty of them being there so early is that using this, we can potentially identify early deterioration, as Ian says, or changes in patients, and the elements of GoodSAM, like the video calling and the radio app, are a way that our volunteers can stay in touch with each other. They can get in touch with another healthcare provider, or perhaps the member of staff or the volunteer group that's going to come along and see that patient next. All in all, it gives us an opportunity to put some people that are qualified into people's communities, into their homes, hopefully aiding their discharge from hospital, or if we're lucky in some areas, helping where people may not need to go straight into an acute hospital. As Ian said, there's a piece behind this that looks at multidisciplinary delivery, and in some areas we're looking to see where we can use some of the healthcare professional volunteers within St John to provide support. And again, apps like the GoodSAM one could be a point of communication between that single healthcare professional who's providing support to a wide group of volunteers that are working across the piece of the area where they're living. It gives us some community resilience, because not only can you help a little bit when you're dealing with people in your community being discharged, but in the event of flooding or in elements of community challenge times, snow, stuff that, again, St John Ambulance has always traditionally been involved in. It gives us a communication tool. It gives an opportunity to have a network of people out there. There is behind it, obviously, a group of trained first aiders, and you've heard other parties tonight talk about helping with a cardiac arrest. These first aid volunteers could also be providing that service of community response into their communities. But the key for us is seeing St John and the communities taking some ownership of their health and being part of a community and supporting each other and their neighbours.
Great. Thank you. If possible, Fiona, I know Fiona's arrived now. It'd be fantastic if you could come and join us. Thank you. And Mark's going to come back and join us as well, so I'll stand up. Fiona, I don't want to put you on the spot, but I feel I need to say, because one of the reasons I'm so keen for you to join us is because we've had a lot of men on the stage today. And we've also been hearing about, can you pass a mic over? All this explosion of ideas and new innovation in the sector, which has been quite traditional and had a very sort of single model for a long time, actually. And I'd love to hear your thoughts about how you see the sector changing more generally, and whether we might even see some more diversity in the sector as well.
Thank you, and apologies for being late. I had to come up from the wilds of Surrey, so not very far from where Richard was today.
I should have introduced you properly as well. Sorry, you're medical
okay.
director, aren't you?
I work for South East Coast Ambulance Service. And I'd like to talk a little bit about the Global Resuscitation Alliance and the way in which globally we can improve the outcome from out-of-hospital cardiac arrest. So if you think about it from a global point of view, there are a huge number of potentially unnecessary deaths a year from out-of-hospital cardiac arrest, with a survival of well under 10%. And what can we do in terms of communities and indeed in terms of technology to improve survival, not just in the first world countries, but also more globally? And the Global Resuscitation Alliance was founded in 2015 in the Utstein Abbey. And those of you who spend a lot of time looking at cardiac arrest survival figures will be familiar with Utstein, and that's where the Utstein template was developed. So perhaps appropriate that we had the opportunity to look again at the ways in which out-of-hospital cardiac arrest survival could be improved. That was in 2015. In 2016, the output from that meeting was endorsed with a document called A Call to Action, which came up with 10 programs which could assist in improving out-of-hospital cardiac arrest survival. And some of those are very dependent on technology. So, for example, setting up a cardiac arrest registry, which potentially can tell you in real time what's happening in a cardiac arrest, so that you can set standards and you can feed back to crews. Looking at what happens in ambulance control rooms, because until you take the call and find out what's happening and can dispatch a resource, then you're not even mobilising people to a cardiac arrest. And of course, early identification of cardiac arrests and using bystanders to get their hands on the patient's chest. And then the inclusion of devices or of technologies like GoodSAM and other ways of mobilising the public and mobilising defibrillators to a patient are, I think, absolutely vital. There's a lot we can do in terms of measuring the way in which crews manage these patients, from downloading information from monitors and defibrillators, so that we can see in real time how well a crew are managing a cardiac arrest and feed back to them and also link that information increasingly to outcomes in the hospital, so that we have a live cardiac arrest registry. So I don't know if that answers your question. It's a bit of a waffly answer, but those are some of the ways in which I think that technology will absolutely improve survival from out-of-hospital cardiac arrest.
I won't push you on the point about lack of women in the sector, but
well, I can answer that as well. Yeah. If you look at ambulance services these days, over 50% of people coming into ambulance services are female.
Great. Great, very good. Thank you. So we've got a few minutes now for final questions. So this is your opportunity to quiz the panel or give any thoughts about future opportunities for innovation. We've got one over here. We'll take a few if I can, if there are more questions.
Hi, I'm Tom Quinn. I'm a professor at St George's. Just really to say, it's really following on from Fiona's point about data. I think one of the things that's come up in my brain anyway throughout the evening is there's a lot of data going to be collected through the various uses of GoodSAM. And Mark will know there's a mantra in surgery, and I'm not a surgeon, but I'm on the IDEAL group, which is setting standards for evaluation in surgery. No innovation without evaluation. So I'd really ask the panel to just give us some thoughts on how we're going to produce the evidence out of all of this that's going to drive the change, that's going to reassure the funders, and what's the threshold for evidence in this new world?
That's great, thank you. Can we take some more? There's one here, two here at the front. Is there one there as well?
Yeah,
Oh, great,
my name
thanks.
is Sudhish Basi. I work with Max Planck Institute in Germany. So I had a question regarding whether this whole paradigm, whether the focus on sort of the volunteer sector and also the recruitment of people from the community, whether it shifts the focus to the community and justifies further, politically motivated cuts to for funding to government health. So I was wondering whether that sort of emphasis on big society will actually lead to smaller government involvement in health.
Great, thank you. And should we take both the two at the front then, and I'll invite the panel to pick their pick. Thank you.
Hi, Nathan Travis, Hereford Worcester Fire and Rescue Service. I'm interested in the prevention side and where GoodSAM could be used in relation to assistive technology in the home. So you get that immediate alert to a responder, but for a range of potential issues. So.
Great, thank you. And last one.
Genevieve Hibbs. In the 1970s, I was in charge of nursing at Cadbury's. We had 9,000 people on the site. And what we were seeing was that we were actually seeing people before they had their cardiac arrest. They were coming to the surgery at a stage before they had their arrest. We started using ECGs. We couldn't read them very well, but if there was any question about the ECG, then we treated it as it was going to be a heart attack and sent them to hospital. So we need to get ahead of the game, so we don't need to be waiting until people actually have their cardiac arrests. Thank you.
Fantastic. Great range of questions. So we've got one about how we make sure we get the data we need to evaluate these things properly. Is this an excuse for cutting budgets? And question then also about prevention and the use of assistive technologies, and also about early diagnosis and intervention. So we've only got about 4 minutes, I think. So why don't we just run through the panel? You can each choose something that you want to respond to. Is that all right? Should we start with you, Fiona?
Okay, so I'll talk about the importance of data. I mean, if you look at the work in Seattle, their mantra there is measure and improve. And unless you gather data, you can't get any idea of how well your people are doing in terms of call handling, in terms of rapid dispatch, in terms of the quality of cardiopulmonary resuscitation they undertake, and therefore link that to patient outcome.
Great, thank you. Richard?
I'll take the one about sort of galvanising the community, because I think that's a really great question. I think there's been a sort of landslide in recognition that pre-hospital care doesn't start when the ambulance arrives, that we sort of used to think. Pre-hospital care starts when the guy gets hit by the car, and actually it's always going to be a delay for professionals to get there. And I think what GoodSAM is allowing us to do is to kind of connect with the community in that way. It's sort of like outreach in terms of, yep, they can give us much better information. If they can give us better information, we can help them to help the patient. So I think it's really moving the care left of ARC in terms of being able to advise and deliver much sooner in that system of care that we've heard about. It takes a system to save a life.
Great, thank you. Ian? Running out of questions.
That's it.
There we are. Two brief comments, one of which is St John has huge numbers of patient contacts and generates huge amounts of data, which historically we've not actually been brilliant at either analysing or reacting to. I think we've got wise to that now, and we are gradually getting much more au fait with the data we've got and using it much more sensibly and effectively. And we're hoping that we're going to appoint a salaried director of research a little later in this year. That's not certain yet, but it's certainly on the list of things that we want to do. With regard to moving things out into the community and therefore facilitating health cuts, I would argue quite the contrary, that unless the community and the members thereof start taking some responsibility for some aspects of their health, then frankly we're going to run out of money an awful lot faster, and therefore we need to rebalance healthcare provision and healthcare responsibility.
Great, thank you. So Mark and Alan, if you could pick up the points about prevention and early diagnosis and intervention, that would be great. Thanks.
I think on the prevention one, it's a challenge, and certainly the Cadbury site is a fixed workforce site, as I know, so you had to some extent an audience in a closed community that would come and see you. Getting communities to engage with this once somebody's within the system, so if somebody's been in for one hospital admission and they're discharged and some of our volunteers go and see them, we've got a captive audience there. I think there really is a challenge in driving communities into use of technology, but once you've got people in there, I think there's a positive benefit. Seeing how simple things like GoodSAM are to use as a way of communicating. Our volunteers going into somebody's house, they can keep an eye on that deterioration during the period they're there. I think in terms of picking up on wider health screening, there are many possibilities that may well need different models of sort of professional type healthcare, taking the district nursing model, and facilities like that are moving forwards. And yes, contacts, for instance, with the fire service, where you go in and do the safe home visits and fitting smoke detectors and things like that's another contact where you see something. And this sort of communication referral tool could be a way of one of your fire crews, for instance, seeing something they think can't quite pin down, think it's a little bit odd, but it could be a portal for getting access to a healthcare professional that can clap eyes on the patient and give an opinion and say whether they do need a face-to-face referral. It's just different ways of doing things that we've traditionally done in the past and drawing the communities together and using the resources differently.
Great, thank you. Sadly, we've run out of time, but Mark, it would be great just to hear a few final thoughts and reflections from you. Do pick up any questions if you want to. But
I just wanted to. Well, the big thing I want to say is thank you to everyone who's here tonight, who's come along. It's just really kind of everyone to give a lovely sunny evening. And I'm now stopping you getting to some drinks, I think, so I'll keep it very brief. But no, thank you all for coming. Most of the people in this room I know in some way, and I can't thank enough people who have engaged with this process and taken things forward. We've got some amazing. So if I start picking people out, it's going to be really embarrassing. But London taking it on in the first instance was just amazing, and then EMAS and Ambulance Victoria and the other organisations around the world who have taken it on, and the new ones coming on now. It's absolutely wonderful to see the collaboration, and I think everyone's really like-minded and want to achieve the same thing. We're really excited that this is an innovative time in healthcare where it's not going to be new antibiotics, it's not going to be new things like that, or new drugs. It's about the logistics. And we're in a time where we can use logistics to really improve patient care. So if everyone's, I hope you've enjoyed this evening, I hope you found it useful. And hopefully we may address some governance, security kind of issues around things. But most importantly, if you think you can come along, collaborate and join this group, we would love to work with everyone. So. That's my summary. Thank you all for coming.
Great, thank you. So it's just a few minutes left before we finish, and want to make sure you all get to go and have a drink afterwards and can continue the conversation. I just want to say a couple of quick thank yous. So thank you to all the speakers this evening who've been fantastic and have kept us to time, which is amazing. Well done. Thanks also to the teams from Nesta and from GoodSAM who have put in an awful lot of time and effort in organising. So thanks to Tara and Katie and Becky from Nesta and Deep Tea as well from GoodSAM. Thank you very much. You're welcome, thank you. If you're interested in other Nesta events, do come along to FutureFest, which is our big festival of the future, largest one in Europe. It's on the 6th and 7th of July at Tobacco Dock in East London. It brings together artists, politicians, comedians, activists to explore alternative futures through talks, performances, debates and immersive experiences. We'll be debating topics like the changing nature of British identity, the future of our cities and how to stay human in an age of machines. And we'll be presenting a host of sessions on health, including how the meaning of health and body and care in a digital age. So we've got a very short video just to give you a little taster to see before you go. And then we'll be done. Can we get the video on?
Ladies and gentlemen, welcome to the future.
Got good music for you to listen to. We might get to see it. Are we going to make it work? Can I have a wave? Is it going to come on? I can't see anything apart from a bright light.
Ladies and gentlemen, welcome to the future.
there you go. Do come along. It'll be a fantastic couple of days. I think there's more information as well in your packs. So that's the end of the event. Please do join us for drinks, and thank you very much for coming.